Dr. Sydney, thank you so very, very much. And, you know, thank you for your review. And I'm going to go straight into a question for you for the panel discussion, which is, for those of us who do not regularly manage mentally unwell patients, um, what are some considerations in the era of COVID of medications to avoid or be concerned about any antipsychotic medications in the management of patients who have acute psychosis and or are agitated?
Is this question for me?
Yes, sir.
Sorry. Yeah, we had a review last year, and people were pretty concerned about what is usually a safe drug and what is usually a safe medication for COVID as well as for psychiatry. I will not go into the politics about who says better or who says less. Based on our own experience, most of the psychotropic drugs, particularly the antipsychotics, does not react with medicines that has been used with COVID across the globe, whether we are talking about remdesivir for moderate to severe cases, or whether we are talking about hydroxychloroquine, which was, the poster boy for some time, or ivermectin. Yes, in some subset like the geriatric population, where we use some central anticholinergics or NMDA receptor antagonists, or drugs like galantamine or memantine, we might have to check whether some of the drugs can actually react. But what from based on our here, at least in India, nothing much was, that we have come across. Theoretically, uh, drugs that we use in adolescent for ADHD, they may react with some of the medicines, but that's about it. More theoretical, but our experience, we really don't have. And if people have seen such interaction, we would be really glad so that we can also manage if we are faced with a similar situation in the future.
Thank you so much, Dr. Sydney. Dr. Janardhan Reddy and Dr. Murray, if you're able to come off mute and come on video, that would be great. Thank you so much. You know, my next question really was for Dr. Reddy. And, Dr. Sydney had alluded to some of the clinical manifestations of neuropsychiatric complications of COVID-19. And many of the providers here in today's conversation are individuals who are actively managing COVID-19 patients, but may not have the same background or clinical training as yourself. So what are some of the warning signs? What are the things that we should look for in patients who have COVID that may also have concurrent neuropsychiatric complications?
It's a question to me, right?
Yes, sir.
Yeah. Um, there's a whole lot of literature on what can happen after COVID-19 infection. Leave aside the acute complications of COVID-19 infection, but there are several large-scale studies that have been published recently, and there are systematic reviews. I think the most common presentations are obviously anxiety, fear of contracting infection and spreading to family members, depression, and quite a lot of healthcare workers have also experienced post-traumatic stress disorder-like symptoms, burnout, and a whole lot of other things, substance abuse. There have also been incidences of increased social ideation, death wishes, and suicidal thoughts. So these have been some of the common psychiatric complications following COVID-19 infection. And there has also been a problem with the fact that people who had pre-existing mental health issues such as anxiety, depression, and severe mental illnesses, many of them have had a relapse of those problems. But I think healthcare workers also experience another kind of problem, perhaps globally, that is a kind of a moral dilemma, which is probably not a mental disorder by itself. You probably could not do the best that could be done. There were infrastructural, issues, resource constraints, and you didn't have ventilators, you didn't have oxygen, you didn't have beds, and you probably sometimes there were situations where you could not help your own colleagues who developed health problems. So there is a sense of responsibility for having not helped, and on the issues that come up with it. In fact, many doctors and healthcare workers have actually experienced this, and this is the kind of situation perhaps which sensitize you to develop stress-related problems. And then, of course, there has been a lot of talk about long COVIDs in people who have had infections. But I'm just specifically talking about certain issues which are more specific to, say, for example, healthcare workers, nurses, people who handled ICUs, ventilators, COVID wards, and they were frequently in and out of quarantine. The whole lot of issues. So we don't know whether the incidence of these health problems are more compared to pre-COVID times, but they're substantial. More than a quarter of patients, people who had, who worked in these situations, developed some or the other psychological problems. And I don't think people are really prepared, because these are the frontline workers. They themselves were leading the healthcare, but they perhaps required more support from the system than others, because they were constantly confronting the mortality which was to happen at such a great frequency at one point of time. So I think these are some of the major issues amongst the healthcare workers. But there is also some literature to say that healthcare workers were no more prone than general population in terms of this kind of healthcare issue, mental health issues. But it's very, very difficult to get that kind of a highly controlled data at this point of time. But it is reasonable to assume that the frontline workers and healthcare workers had their own set of mental health issues. I think of which we are perhaps more familiar now than a year ago, and probably systems have to really think of how to support healthcare workers who manage these kind of crisis situations.
Thank you, Dr. Reddy. I think you already took me to the next part of the conversation, right, from clinical considerations in COVID patients to healthcare workers. So, Dr. Kumar, a question for you. The terminologies that I've heard are anxiety, depression, suicidal ideation, post-traumatic stress disorder. What are the differences between these four diagnoses?
Thank you. Thank you, Bhakti. I'd go on to talk about one after the other. I'll start with first the definition of stress itself. Stress is universal and not just a human experience. It happens in humans, organisms without a nervous system, plants, and even inanimate objects. For example, in inanimate objects such as metals, what is stress? Stress is conceptualized as a resistance offered to the subject to the external force. When external forces either compress or expand, causing tension, the metal reacts by, distorting itself to counterbalance the forces, and that is called as a strain. So, for example, in plants, in agricultural plants, plants are considered to be under stress if they're subjected to less than ideal conditions for growth, and there are established methods of quantifying stress both in plants as well as in in inanimate objects. However, the stress in living organisms is more complex. In simplest terms, if one may have to say, the common denominator of stress in living organisms seems to be a simple activation of a survival process involving physiological arousal response to threatening or unpleasant stimuli. So also, not only this, the manifestation of stress becomes increasingly complex as the humans are evolved species and have a well-developed nervous system. So the response to stress varies quite a bit. So that's about the definition of stress. Now coming to the anxiety. The anxiety is to be differentiated from fear. For example, fear is an emotional response to real or an imminent threat, whereas anxiety is anticipation of future threat. So the threat is not actually real, but an anticipation of a future threat. Obviously, these two states overlap, but there is often a difference which can be clearly elucidated. Now, post-traumatic stress disorder is a kind of illness which which is a consequence of a severe stress. I mean, the stress here should be of an exceptional nature, which can cause problems to almost all of the human beings that are exposed to this. It arises as a delayed or a protracted response to a stressful event or a situation, either short or long lasting, of an exceptionally threatening or catastrophic nature. So these terms are important. And of course, many of the symptoms are anxiety-related symptoms. Typical symptoms include repeated reliving of the trauma in intrusive memories or dreams. Those are called as flashbacks, occurring against a persisting background of a sense of numbness and emotional blunting and detachment from other people, unresponsiveness to surroundings, and so on and so forth. Also, there is usually a state of autonomic hyperarousal with hypervigilance. Actually, after the trauma ensues, the earlier response is called as the acute stress reaction, and after probably for about which ranges from weeks or months, maybe up to 6 months, what we would see what is known as the post-traumatic stress disorder. And COVID-19 has all the qualities to be called as catastrophic events for those for many of those who are exposed to this. So it's not about everyone. It's not to say that everyone develops PTSD or post-traumatic stress disorder. With people with some vulnerabilities, people with some other risk factors, psychological risk factors, or those with a family history of development of anxiety disorders, they may be under some risk of developing these things. So that is about stress, fear, anxiety, PTSD. And now coming to the issue of burnout. Now, burnout is something which is seen in healthcare workers. I mean, Professor Janardhan Reddy also elucidated about this particular aspect. Burnout is seen among healthcare workers after exposure to a chronic kind of stressful situations. Of course, working in this kind of environment is nothing short of a stressful environment. So described classically as a triad of emotional exhaustion and a sense of depersonalization, that is loss of one's empathy, caring, and compassion. That kind of feeling wouldn't come, and a decreased sense of accomplishment. So these also may occur in varying degree. Maybe in one, some persons may have one symptoms in predominant. Of course, burnout can have a significant impact on competence and the impact on the healthcare delivery. Some of the risk factors could be long working hours, worry about the risk to self as well as the family, concerns about inadequate personal protection materials, separation from family loved ones. So these are some of the things that are there, and of course, the pre-existing vulnerabilities in the form of mental health issues and addiction issues. How to prevent and combat burnout, self-care, and what one can do about himself or herself. There is a role for the team leaders and supervisors. If time permits, I'll go into these things. Otherwise, I'd like to stop at this. Some of these strategies can be discussed even future. Thank you.
Thanks, Dr. Kumar. Yeah, time does not permit, unfortunately. We have a very interesting presentation still pending. But what I would like to say is there's a lot of really great questions in the chat. So if our experts could look at the chat and respond to some of those questions around the difference between COVID-related psychiatric disorders versus nascent psychiatric disorders, that would be great. And I also think we'll have an evidence-based review sent to all of our participants. So if there's resources that you can send to us, we'll definitely send them out. Just one small quick question. Dr. Reddy, you said that the prevalence of mental health complications in healthcare workers was greater than 25%. I personally have experienced a couple of cases of suicide in healthcare workers during COVID-19. In India, and Dr. Kumar, Dr. Reddy, can you quantify what the prevalence of severe burnout and or suicidal ideation in healthcare workers is? And Dr. Murray, could you do the same for the United States? How frequent is this problem?
I must say that I really don't think there's every systematic data on that in the Indian population, how frequent are suicidal thoughts and suicidal preoccupation, death wishes. In fact, much of the literature on psychiatric aspect, mental health aspects of COVID-19 has come from China. If you look at the big studies, much of the data is from there. Nowadays, there is some data from Europe and America, but I am not aware of suicidality in the Indian population being studied systematically. Naveen, you may have any recent access?
Yes, sir. One report says that in the after the onset of COVID, particularly in 2020, 34 suicides have occurred daily, especially among students. So that's the number which we have to look at it, because as Professor Reddy was
That is
saying,
from the National Crime Bureau, right? I mean,
yes,
it's
yes,
very difficult
that's all
to
we want.
attribute to
Absolutely.
COVID-19 or
Yes, yes.
design and the effects of other problems. So
Yeah.
I must say there's no systematic data on that.
Absolutely, absolutely. Talking in terms of mental health issues in general population, sir, one Indian Psychiatric Society survey in April-May 2020 that quantified, that about 35 to 40% of the general population may have had one or the other mental health issue in terms of the stress and anxiety symptoms or depressive symptoms. So those are the things that we have as of now.
Thank you. And Dr. Murray, are you able to comment on if we have any systematic data from the United States?
I can comment a little bit. I don't think that there's real science since COVID started. There's been a wide range of surveys done. So for example, physician burnout has increased from 46 to 54% in one of the surveys. As far as suicide, what we're seeing come out of the data is just that there is an increase. And it does follow national suicide rates here, where females are higher. And what they do know is that in surveys, the suicidal ideation is significantly higher.
And Dr. Rajani, and apologies for having to ask you to keep this answer short. I know that your work in particular has focused on healthcare worker resilience and some of the initiatives in Karnataka. Could you tell this audience about what were some of the activities that have been championed by the state of Karnataka that have been effective in supporting healthcare workers that could be adopted elsewhere?
Yeah, thank you very much. Yeah, basically we have mental health professionals in all the districts in Karnataka through district mental health programs. So usually, you know that when the whole healthcare system is trained in treating pandemic and inside the hospital, mental health would take a back seat. But in Karnataka, we planned, to be precise, on March 7th itself, that is March 9th, we had first case. But March 7th itself, we planned that mental health care services also should be given for all those who were COVID positive, those in isolation, quarantine, and for migrants and for healthcare workers. So we started what is called as teleconsultations. These are the outbound calls which were given by the mental health team across the state to all those who were COVID positive. And those we have given around 24 lakh teleconsultations till now, and it is still ongoing across the state. Specifically for healthcare workers, we started, as you said, there were 2 suicides in the Health and Family Welfare Department itself in Karnataka. Then we started caring for COVID healthcare warriors. We conducted around 683 sessions to sensitize and train all the healthcare workers on stress management. And we have also conducted a survey wherein 3083 healthcare workers participated, and we found out that 23.8% reported anxiety and 20% depression and other few substance abuse, suicidal ideas, all those things. So after conducting these 683 sessions across the state of Karnataka, specifically on stress management. And in that, more than 2,000 doctors and more than 9,000 other healthcare workers also had participated. And even now we give teleconsultations to healthcare workers and specifically to doctors also. So we have given around 30,000 consultations. This is, including other than what we are catering to those who are COVID positive and, isolated, quarantine, migrants and all. So these are the few innovative things which Karnataka has taken up, and it is ongoing.
Well, I really hope that with the RISE program, we can continue to expand the scale of the really great innovations you've started in Karnataka.